I put together a list of 10 reasons why a patient may have elevated eye pressure in the ED. If you want to learn more about them, keep watching. I'm Dr. Alana Jasper Trotter. I'm a board certified ophthalmologist, and my goal is to make eye care a little bit easier. Be sure to click that subscribe button. New videos are popping through. There are many types of glaucoma, but in this video, I'm going to be focusing on a few types of glaucoma that may present to the ED with elevated eye pressure. If you work in the ED, chances are at some point a patient with closed angle glaucoma is going to be walking through your doors. In angle closure glaucoma, the drainage angle of the eye is blocked or narrowed due to appositional or synechial closure. The aqueous humor can't drain appropriately while additional aqueous humor continues to be produced. So that leads to an intraocular pressure increase. In appositional closure, there's something that's physically blocking the drainage mechanism, and that can happen in acute pupillary block where there's a functional block between the iris and the lens. Normally, the aqueous humor is produced by the ciliary body, and then it moves from the posterior chamber through the pupil into the anterior chamber, and then it exits through the trabecular meshwork. So that's the outflow. So if the iris is stuck to the lens, and all the while the ciliary body is continuing to produce aqueous humor, it can no longer flow from the posterior chamber to the anterior chamber through the pupil. And so what happens is it'll start to build up, and then that's going to lead to the iris bowing forward. So that's where you get the bowing of the iris because there's all this pressure that's building up. So here, the anterior chamber is actually deep centrally, but peripherally, the iris can get pushed forward so much that it's actually narrow peripherally. In synechial closure, there's adhesions that develop over the drain, and that can impede aqueous humor outflow. There are two main types of angle closure glaucoma. Primary angle closure, which is mainly due to the patient's anatomy, as well as secondary angle closure glaucoma. The eye pressure can increase to pretty high levels, which can be vision threatening, especially in acute angle closure glaucoma, which is commonly due to pupillary block, where the pressure can rapidly rise and needs to be treated as soon as possible. These patients come in with a hot, steamy eye. They are uncomfortable, pain, photophobia, nausea. It's the first time you see a pupillary block. The next time you see something similar, it's going to be in your mind. Primary open-angle glaucoma is a common type of glaucoma where the eye pressure is elevated, the drainage angle is open, and there's glaucomatous optic nerve damage with corresponding visual field defects. It's often asymptomatic until it becomes more advanced where there can be severe vision loss. When treatment is indicated, one of the main goals is to lower the eye pressure. So that can be with glaucoma eye drops, laser or surgical procedures, or a combination of those treatments. So how could a patient with POAG present to the ED? Well, if the patient ran out of their glaucoma eye drops, or if they're not compliant with their eye drops, that could lead to a pressure spike. For example, let's say a patient with moderate POAG on 2 glaucoma eye drops ran out of their medication 1 month ago and they haven't been seen since. And now the patient is presenting with a red eye, discomfort, and pressures in the 30s. Neovascular glaucoma is a secondary form and often complicated type of glaucoma. This often occurs due to some form of retinal ischemia that leads to an abnormal growth of blood vessels in the anterior chamber, like on the iris, leading to neovascularization of the iris or NVI, and over the drainage system of the eye, so the angle. So this can impede or even block the drainage system, which then obstructs the outflow of the aqueous humor and elevates the eye pressure. And some conditions that can lead to retinal ischemia and ultimately neovascular glaucoma include diabetes, CRVO or central retinal vein occlusion, as well as ocular ischemic syndrome, which is associated with severe carotid artery occlusive disease. There are 5 different types of lens-induced glaucoma, and in this video, we're going to be focusing on phacomorphic, which is a type of secondary angle closure glaucoma. In phacomorphic glaucoma, phaco referring to lens, the cataract progresses forming a mature cataract that pushes the iris forward, which can lead to pupillary block. So this can occur in an acute setting if the patient has an intumescent cataract where the cataract swells and becomes opaque. It could also be chronic as the cataract gradually matures over time. So how could this present to the ED? Let's say there's a 72-year-old male who lives in a remote area and has never seen an eye doctor, and he comes in with an acute red eye, pain, nausea, a mid-dilated pupil, a white cataract, and a pressure of 54. Normal intraocular pressure generally ranges from 10 to 21. and an eye pressure that's greater than 21 on more than one occasion with no signs of glaucoma is ocular hypertension. It's often incidental because patients are commonly asymptomatic. It is a risk factor for glaucoma, and patients with ocular hypertension are called glaucoma suspects and are monitored by an eye doctor. So how could this present to the ED? Well, let's say a patient comes in with a chalazion or stye, and the eye itself looks completely fine. It's white, there's no corneal abrasion. All the exam findings are localized to the affected eyelid. But then you check the eye pressure and they're found to be 23 in the right eye and 26 in the left eye. Another scenario is if a patient is a steroid responder. So the intraocular pressure can increase as a result of someone being on a steroid. And it's not just steroid eye drops. It can be a steroid in any form: oral, IV, injections, even nasal sprays. This generally occurs weeks after starting the steroid, but it could start earlier than that. The patient may have symptoms of elevated eye pressure depending on what that value is and how fast it increased. But they could also be completely asymptomatic, and it might be an incidental finding. A hyphema is blood in the anterior chamber, which is the space between the cornea and iris that houses the aqueous humor. In the ED, this commonly occurs following a blunt trauma. The trabecular meshwork drains the aqueous humor and it helps to maintain the eye pressure. But in a hyphema, the red blood cells can clog the trabecular meshwork and thereby increasing the eye pressure. The eye may also have sustained enough trauma that other structures in the drainage angle may also be damaged, increasing the risk of glaucoma. So this is why it's really important for these patients to have continued care with ophthalmology. As long as there's no open globe, a traumatic hyphema is often managed medically, but depending on how much blood there is in the anterior chamber, as well as what the eye pressure is, those exam findings are really important as an ophthalmologist because it can help determine whether or not the patient actually needs to go to the operating room to have an anterior chamber washout to get that blood out, to try to help bring down that pressure. If the pressure gets really high, the longer it stays high, the higher the risk of developing optic neuropathy. A trauma can also lead to iris inflammation called traumatic iritis, and that leads to inflammatory cells in the anterior chamber. So this can lead to an increased intraocular pressure if the inflammatory cells clog the drain, or if, like in a traumatic hyphema, there's trauma to the angle. But keep in mind, iritis, which is a type of uveitis, can also lead to decreased intraocular pressure due to ciliary body shutdown. So the ciliary body produces the aqueous humor, and that can be affected by the trauma or inflammation. So if you have impaired ciliary body function, you have decreased aqueous humor production and decreased intraocular pressure. A chemical splash injury to the eye is an ophthalmology emergency. And the most important thing to do from the eye standpoint is irrigate, 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 and then irrigate even more. Even before calling ophthalmology, irrigate the eye. So that's like chemical splash, irrigate. Continue copious irrigation until the pH is 7. It's important to know what type of chemical hit the eye, so whether it was acidic or an alkali. An alkali can cause more damage. I mean, both, can cause damage, but alkali more so. And an alkali injury can increase the eye pressure, which is why I included this in the list. Postseptal orbital cellulitis is an infection that involves tissues posterior to the orbital septum. It can be severe and there is risk of vision loss, so it definitely warrants urgent attention. It typically involves IV antibiotics and a hospital admission, and would definitely recommend consulting ophthalmology. I don't know why I smiled, but I guess because that's me. There's different ways in which the intraocular pressure can be increased. It can happen due to significant periorbital or intraorbital inflammation and edema. And if there's a significant amount of edema that is within the orbit, which is a closed space, that can lead to a risk of compressive optic neuropathy. It can also be caused by an intraorbital abscess that's leading to a mass effect, as well as if there's an involvement of the cavernous sinus. So if the infection spreads posteriorly to the cavernous sinus, that could lead to a cavernous sinus thrombosis, which could potentially be vision-threatening or life-threatening. Orbital compartment syndrome is an ophthalmology emergency that occurs due to an acute increase in orbital pressure. Because the orbit is a closed space, if something is in the orbit that shouldn't be there and it's taking up space, that can increase the orbital pressure and potentially damage the optic nerve, the retina, and the surrounding structures within the orbit. And if it's not treated fast enough, it could lead to permanent vision loss. There are many causes, but some to highlight: trauma that leads to orbital hemorrhage or orbital emphysema, postseptal orbital cellulitis, orbital tumor, and rarely orbital fat prolapse. I did a video on how to manage orbital fat prolapse in trauma, and I talk a lot more about how it could lead to orbital compartment syndrome, so be sure to check it out. I'll leave a link down below. There are many causes of orbital compartment syndrome, but the key is identifying it quickly and treating emergently by doing a lateral canthotomy, cantholysis, to help relieve that pressure. One thing I learned in my training was that anytime I was being pimped on what's the differential diagnosis of this, what could potentially cause this, when in doubt, herpes. Herpes, herpes, herpes. Unfortunately, herpes can cause pretty much anything and everything in the eye. So if you're ever asked a question and it relates to the eye, what could cause it? Herpes. When in doubt, herpes. Herpes simplex virus and varicella zoster virus can lead to uveitis that can present with elevated intraocular pressure. Now, that may be contrary to what you've learned with uveitis, because oftentimes uveitis leads to decreased intraocular pressure, just like we talked about earlier in the video, because it can lead to ciliary body shutdown. But there's a handful of diagnoses that can present with intraocular inflammation and lead to an increase, and that's where herpes comes in. In the setting of uveitis, the herpes virus can increase intraocular pressure because the inflammatory cells in the anterior chamber can clog the drain. There can also be inflammation of the trabecular meshwork, which decreases the outflow of the aqueous humor from the trabecular meshwork, thereby increasing the eye pressure, and that's called trabeculitis. And it's been reported that the eye pressure can get pretty elevated to the 40s, 50s, or even higher. So how could this present to the ED? An example, a 33-year-old female with a unilateral acute red eye comes in with symptoms that sound like iritis, photophobia, eye pain, blurry vision. We mentioned that the eye is red. And let's say the pressures in the affected eye is 44, but in the other eye, it's 16. Patients are often seen one day after intraocular surgery. And one of the main reasons is to check the eye pressure. In cataract surgery, it's not uncommon that the pressure in the surgical eye is transiently elevated shortly after surgery, so hence the post-op day 1 appointment. And sometimes it could be just mildly elevated, like 22, 24. But it could be higher in the 30s, and that could be why a patient is really symptomatic. And this could happen due to retained viscoelastic, which is a clear material that's injected in the eye during cataract surgery to help maintain the shape of the eye and protect the corneal endothelium. It's removed at the end of surgery, but sometimes some of it's hiding out, and it could temporarily block the drain, leading to a pressure spike. There's also a rare condition called toxic anterior segment syndrome, which presents as an acute, severe, sterile, non-infectious intraocular inflammation that's localized to the anterior segment. So it's a rare complication of intraocular surgery that's thought to be due to a toxic reaction from something that's introduced to the eye during surgery, like contamination of a solution or inadequate sterilization of surgical instruments. It occurs, and this is one of the keys here, is the time frame. It occurs within 12 to 48 hours after intraocular surgery. Compare that to postoperative infectious endophthalmitis, which generally develops 2 to 7 days after surgery. So we've just gone through 10 reasons why a patient may have elevated eye pressure in the ED. But what about acute painless vision loss? And there are definitely diagnoses that you don't want to miss. Check out this video next where I share one of my best mnemonics.